Okay, wonderful. So we can start the session, and today we will take forensic medicine and toxicology, right? So the very first question was about a child who had presented to the forensic department complaining of anal pain, right? And it was suspected that he has been sodomized, right? Now we need to investigate. So what we'll do, we'll take a anal swab and we will subject it to some test, and the test is showing these yellow crystals, right? So the anal swab, it was subjected to some test, and this is the interpretation of that test. We can see there are yellow shaped crystals here. So some are needle shaped, some are, hello Monica V, very nice to see you after a long time. So we can see yellow crystals which are either needle shaped or rhombic shaped. Narsimha Kumar BL, very good. Yes, so since the case is of sodomy, right? So if the case is of sodomy, so definitely the investigation will go towards searching the seminal stain, right? And this seminal stain will be subjected to Barberio's test, right? So it will be subject to Barberio's test. And what we do actually in Barberio test? Yes, very good, Shanwaz, very good. So what we will do Barberio test, we put a picric acid solution, right, to the stain. So right, so we add a picric acid solution, that is also known as Barberio's reagent. And if this stain is a seminal stain, right, now if it is related to semen, there will be presence of spermine, right? And now this spermine will add with picric acid, and it will form the spermine picrate, right? And this spermine picrate will appear as yellow colored, needle shaped or rhombic shaped. Okay, so this is the, very good Narsimha, very good. Yes, so this is the total basic description of Barberio's test, right? So this is the Barberio's test, and this is how we treat that stain, seminal stain, possibly with the picric acid solution, and we will look for these yellow colored needle shaped or rhombic shaped crystals. Nadeem Akhtar, yeah, very nice to see you, gentlemen. Good. So now the problem is that these crystals, if you see, they are not of a fixed shape, like they are not all needle shaped or not rhombic shaped. Yes, very good Narsimha, yes, you are right. Now these are not fixed shape. So if I try to draw some outline, you will see these are so much irregular, right? So this is known as pleomorphic, right? So this is pleomorphic. Pleo means many, morphic means forms. So either it can be needle shaped, it can be rhombic shaped, but the appearance will be yellow, right? So particularly in case of any anal assault, and if we are suspecting, or any other case of even rape also, and if we are suspecting the stain to be a seminal stain, we can subject it to Barberio's test. And in relation to this question, this is the classical appearance of the Barberio's test, and these crystals are formed because of spermine picrate, right? So the solution used is picric acid solution, and it reacts with the spermine which is present in the seminal stain. Now here you need to remember one important point, that the spermine is checked here. It has nothing to do with spermatozoa, right? So this is very important here. whether spermatozoa is present or absent, test is unaffected, right? So please remember this special point, that spermatozoa can be present or absent. It doesn't make any difference, because the test doesn't address spermatozoa actually. It just focus on the presence of spermine, which is a component of seminal stain, and when reacted with picric acid, it is going to give you yellow crystals of spermine picrate, right? So this is the basic of Barberio test, and this is the classical appearance of the crystals of Barberio test, right? So this is in short about Barberio's test. Now let's move on to another question, and I think it's a very basic question. I am very sure all of you must be knowing it, and let me see. So a patient is dependent on cocaine, right? Now what he is doing, he is consistently scratching his skin and just because of that scratching, he developed scratch marks on skin. Now what this process is actually known as, so here one point is of course cocaine, right? Second is scratching, or what you call itching. Now what this actually is, very good Shanawaz bhai, it's a classical Magnan's symptom, right? So it's a classical Magnan symptom, which is actually, that is also known as cocaine bugs, right? So cocaine bugs, and this is actually nothing except a kind of tactile hallucination. Clear? So this is Magnan's symptoms, or sometimes you might have some other word, something like formication, cocaine bugs, or insects crawling under skin. So that is all related terms which are very commonly used for this particular substance of abuse. So this is cocaine chronic poisoning, right? So this is very important. This is especially seen if the person is taking cocaine since a long time, right? So this is a classical Magnan symptoms or cocaine bug. Yes, you can say anything, but I would request you, please don't be wrong in this question. And this is a question which has been repeated over the years in any exam, whatever you take, FMG, AIMS, whatever. So, and this is a very classical and very favorite questions, right? So this is all about the chronic poisoning. Now I have seen certain questions where they have not mentioned all these classical symptoms of chronic cocaine poisoning. Instead they have given you some acute poisoning features. So I'm just taking the opportunity to discuss those features as well, so that in case if you find something related to that, you shouldn't be wrong, right? Now chronic is like, usually the question is based on tactile manifestations and all, tactile hallucinations and all. Now in acute poisoning of cocaine, right, the manifestation is actually increased sympathetic overactivity, right? So that is increased sympathetic overactivity, and I think most of my dear students must be knowing what we'll see when there is increase in sympathetic overactivity. So number one, what will happen to blood pressure? It will increase. What will happen to heart rate? It will also increase. What will happen to respiratory rate? It will also increase. And what will happen to pupil? Very good, Sangmitra. You just pointed out before I could speak out, right? So yes, so pupil will dilate, and of course that is known as mydriasis. Clear? So at times, just to confuse you, they won't give you the exact chronic poisoning features. They might put you in this acute thing, so you should know this as well. So the point which you need to remember is tachycardia, tachypnea, hypertension, and dilated pupils, right? So please, and of course, yeah, diaphoresis is also good. So diaphoresis, very good. That is increased sweating, right? So this is increased sweating. So these are classical sympathetic overactivity features which are seen in acute cocaine poisoning, right? So cocaine is a very favorite topic, and you can have question in any form, right? So just remember this much. So let us move on to next question, and that was about exhumed bodies. We can check which poison. I think all of you must be knowing what is exhumation. Exhumation means digging out of the body from graveyard, right? So suppose if very good Narsimha, very good Sangmitra, both of you are correct. So suppose if person has been already, is in the graveyard, the dead body is in the graveyard, and later on it has been there has been some need of some investigation, then that body is taken out and then the required process is carried out, right? So again, the important thing is that the process, there are just few basic guidelines. It has to be started early morning, right? Now I think all of you can understand why we started early in the morning, because we want to finish the process in daytime, or the natural light, you can say. Clear? So that's why we start early, so that we can finish the inquest process within natural light, right? And yes, of course, arsenic is one poisoning. Arsenic is one poison which can be found in decomposed bodies, charred bodies, or even in ashes, right? So this is the unique feature of arsenic poisoning, and I'm very happy that most of you know this fact. Okay, so very good. So this is in short about exhumation and arsenic poisoning, right? So, and just an image to discuss some features. And here, if you look at nails, you will see transverse lines. These are known as Aldrich-Mees lines, right? So these are Aldrich-Mees lines, which are the transverse lines on nails, right? Then what we can see, there is garlic breath, right? So garlic breath. Then there can be neuropathy, right? And hyperkeratosis. There can be raindrop pigmentation. So these are some features, and of course this is one agent which is used as rodenticide, and therefore you have this picture of a rat. So this is in short about arsenic poisoning, right? Chalo, next question. Now this is one question which has been asked in yes, Narsimha Kumar, very good. Aldrich-Mees lines, which are the transverse lines over the nail, and raindrop pigmentation, of course. Wonderful. Now there is next question is also asked in FMG as well. So now here a person was brought for autopsy, and there was no tattoo mark visible, but the family members were saying that he was having tattoos. Now how you would confirm whether he was having tattoos or not? Very good, Narsimha, very good, Sangmitra. Yes, what happens whenever there is tattooing, if suppose this is epidermis, right, and deep to epidermis is dermis, then finally we have hypodermis, that is the fat layer. Okay, so what happens whenever there is tattooing? So the dye is injected somewhere here in the dermis, and from dermis, if suppose this is the lymph node here, the dye can, by the way of vessels, it can go into the lymph node, right? So with putrefactive changes, Shanawaz bhai, absolutely right, lymph nodes. So with putrefactive changes, it might be possibility that the skin is decomposed or the tattoo is not visible. So what we can do, we can examine this lymph node for that ink of the tattoo, right? So this is the ink of the tattoo here, and that will put us in a position to talk to the relatives whether he was really having tattoos or not, right? So this is the explanation for this particular question, that why we prefer examining lymph nodes for the residues of ink. Okay, chalo. Next question, it was about willful false evidence, and it was given via witness while under oath. Now what is this known as? Willful means knowingly. See, patient is under oath, right? Because many times you must have seen that, yes, Sangmitra, I got the answer right. So patient, the witness is under oath, and he has already taken the oath that whatever I'll say, it will be true and to best of my knowledge and all those words. But when it comes to producing evidence, he started saying something wrong, which is motivated by some other reason, right? So there is willful utterance of falsehood. So this is known as willful utterance of falsehood, and this is nothing except perjury, right? So the person knows that he is speaking the truth, he is speaking the lies, but he had some motive behind, so that is known as perjury. And I think this image might help you, like the person has taken only $1,000, but this person is saying that he has taken my $6,000, right? So this is perjury. He knows the truth, but he is saying a lie. He is just twisting the facts just to deviate the examination and all, right? So this is perjury, right? Willful utterance of falsehood. He know that he is speaking a lie, but still he just continues. Now about the next question, the thing is civil negligence, right? And it's of course against a doctor, and here the onus of proof. Now onus means responsibility. Now onus means responsibility. Very good, Narsimha, very good, Sangamitra, both of you are right. So the onus of proof lies with the patient. Yes, that's true in cases of civil negligence. Now the question is, what is this civil negligence? What is criminal negligence, right? So what is this civil negligence and what is criminal negligence? So we have to just take few words about these terms so that the whole picture becomes clear to you, right? So if we talk about civil negligence, okay, so, and of course the word is negligence, so there has been some some shortage on the part of doctor, and here we can write criminal negligence. Clear? So now here the very first difference is the degree of carelessness in simpler terms, right? So here in civil it is, you can say it's just a minor degree, but in criminal you can say it is a major negligence. Now major negligence, we can see it can result in some even death of the patient, you can say death or severe disability, right? So this is the major thing which can happen in cases of negligence, right? So this is the degree of carelessness. Now in civil negligence, if you take examples, suppose if some disease, the treatment has to be carried for say 5 days treatment is needed, right? uh, Theoretically, or which is usually prescribed, right? So suppose if 5 days treatment is needed, and maybe by under some influence from some pharma company or some other interest, the doctor is carrying the treatment for 2 months, right? So that is civil negligence case, right? Or if the diagnosis is not properly done, and all those things will come into civil negligence. Criminal, if there is gross, and you can use the word gross here. So there is gross negligence on the part of the doctor, and it was such a negligence that could have resulted in the death of the patient as well. So that is criminal negligence, right? Now here, in this cases, the onus is on patient, right? So the onus is on patient to prove that the doctor is wrong. But in cases of criminal negligence, the onus is on doctor to prove himself that he is not involved in all this. He is not responsible for all this, right? So he should not be convicted in this case, right? So here the patient has to prove that doctor is guilty, and here doctor has to prove that he is not guilty. Okay, so this is civil negligence and criminal negligence. Okay, and therefore in civil negligence it is all up to the patient to prove that the doctor was short of the required level of skill and care. And one more point you can add here, like if you have taken consent, then it is protective for doctor, right? So if you have taken consent, then you can say that I have already told the patient about this. If he was having any objection, he should have told me at that time, right? So consent becomes a defense for doctor only in civil. It will not work in criminal, right? So these are few points which you should know about civil negligence and criminal negligence. Okay, so if there is any question about the onus of proof, then in civil negligence the answer has to be patient, and if the question is about the onus of proof in criminal case, then it is up to the doctor. Okay, so these are few things which you should remember, and I think mostly the question is based on these facts only, right? So civil negligence and criminal negligence. Now this is a very beautiful question. As per POCSO Act, a child was brought for age estimation, right? So and that is the prevention of child sexual activities. So it was the child who was brought for age estimation, and then a X-ray wrist was given. Now looking at the wrist X-ray, now you have to tell, or you have to calculate the age of the child. So actually the question was about the it was the anatomical basis was about the ossification centers of the wrist, and it has been integrated with the forensic scenario. So any idea, like, and can you guess what can be the answer here? Now before answering such questions, the very first requirement is that you should know what is the time period for ossification of those bones. If you know the ossification centers, it is quite easy to answer. In cases of wrist, it is even more easy for you to answer, and let me tell you the trick. Now what you need to do, I think firstly you need to identify the bone. So I think everyone can identify this is radius, this is ulna, right? This is first metacarpal, this is second metacarpal, third, fourth and fifth, right? So now we will count the number of carpal bones. Okay, so simply just count 1, 2, 3, 4, 5. This is sixth, okay, very small, and this is seventh. So how many carpal bones you can count? It means these bones have ossified, and now we can see them. The ossification centers have come. So we can see 7 bones in the wrist area, and we know that there are 8 carpal bones. So for the time being, I'm not going into anatomy. Let me give you the trick first. So just count the number of carpal bones. If they are 7, then you can straight away mark the answer as 7, right? And if you can see 8 carpals, if you can see all the 8 carpal bones, then it is 12 or more, right? Because the last one, which is pisiform, actually it comes between 8 to 12 years. So if you can see pisiform, it means 12, either 12 or beyond. So this is in simple. And even like you can remember, if suppose if there is a different x-ray where you see only 4 carpal bones, suppose you see only 4 carpal bones, then in that case the age will be 4 years, right? So here we are seeing 7, so 7 years. And what I mean to say, every year there is increase in 1 bone. So if you see only 1, the age is 1 year. If you see 2, the age is 2 year. 3 year. 4 bones, 4 year. 5 bones, 5 years. 6 bones, 6 years. 7 bones, 7 years. But 8 bone, 12 years or beyond, right? So this looks very tough, but it's very simple. So if you can count 7 bones, simply mark 7 years. Now we will take the anatomical concept. Okay, now I think you know that there are total of 8 carpal bones which are arranged in rows of 4, so which are arranged in 2 rows, and each rows contains 4 carpal bones, right? So the counting is always started from lateral to medial. So suppose if this is radius here, if this is radius, this is ulna here, right? Then we will go from here, scaphoid, right? Then lunate, then triquetral, and on the top of triquetral we have pisiform, right? So somewhere here we have pisiform, right? So this is the proximal. Then trapezium, trapezoid, then capitate, and then hamate. Okay, so something like this. So we are going from lateral, of course this is lateral side and this is the medial side. So we are counting from lateral to medial. Okay, so this is the series of the carpal bones. Now when you have to count, the counting has to be anti-clockwise, right? So okay, let me show you in the diagram first. So firstly I'll show you the carpal bones rows wise, right? So this is a right wrist, and firstly I will be drawing the proximal row. So scaphoid first, okay, lateral most, then lunate, right, then triquetral, okay, this is all triquetral, and the pisiform actually overlies triquetral. Okay, so these are the proximal row carpals. This is of course lateral side and this is the medial side. Clear? And of course this is the right hand. Fine. Now we will take the carpal bones of the distal row. So starting with trapezium, followed by trapezoid, right? Then we have the largest, that is capitate, and the medial most in the distal row is of course the hamate. Okay, right? And now in hamate you can see one prominence like this. This is actually the hook of hamate. Okay, so this is how we have arranged. Now when we have to remember the sequence, because many times they might ask you ossification center for a particular carpal bone, so you should remember the for a particular bone you should remember the time for ossification as well. Muhammad Shahnawaz bhai, very good. So we will start with the largest bone, that is capitate. So capitate first, and then we will rotate anti-clockwise. So how is this anti-clockwise? It will go something like this, right? So this is anti-clockwise. Clear? So this is anti-clockwise. So capitate is at 1 year. If you see a X-ray of a child who is 1 year old, you will see only one carpal bone, and that is capitate, right? Then the next to ossify in the next year to ossify is hamate, right? Then third year there will be ossification of triquetral. Please remember this is triquetral. Okay. Then fourth year there will be ossification of lunate. Fifth year there will be ossification of scaphoid. Sixth year there will be ossification of trapezium, and seventh year there will be ossification of trapezoid, right? So this is how you will remember 1 to 7, and for pisiform the range is actually 8 to 12 years, but in many descriptions you will find 12 years mostly, right? But the range is 8 to 10 years. So in simpler words, 1 2 3 4 5 6 7 12, you can remember like that. Okay, so it is quite easy if you know this particular concept. But even if you don't know, simply count the number of carpal bones and you will get the exact age without any error, right? So it looks difficult, but it is extremely easy to answer, right? So again, so I think if we can just we can just apply this concept on the X-ray. So this is of course the capitate in the distal row. This is the hamate, right? This is triquetral. Then this is lunate. This is scaphoid. This is trapezium, and this is trapezoid. So we can see the 7 carpal bones which have ossified till now, and therefore we can say with surety that the age is 7 years and beyond, right? So it is 7 years and beyond. Okay, so 7 years and beyond, but of course less than you can say 8 years, or if not 8 years then 12 years, because that is the time period for ossification of pisiform, right? So this is how you can apply the concept. So I think, and this is how the pisiform actually looks over the triquetrium, right? So on the, this is all triquetrium, okay, or triquetral, it is sometimes pronounced like that, and on the top of that we will find the pisiform. So this is the pisiform. Okay, so these two bones look like this, and therefore you have to have a look at the X-ray properly, because they are overlapping, they are not separate. So at times student miss that, and this can be easily seen by increased lucency. So if you look here, just look at the appearance of the bone here, just look here and just look here, so white, and this white is because there is a bone overlying a bone, so it is giving more white appearance, right? So this is in short about this particular anatomical basis of this question. Now, what is this phenomena? What you can see here, of course, I think most of you must agree that this is a post-mortem change. Now, what is this actually? What you can see here? What is being shown in the image? It is very easy to identify. Anyone? What is being shown in the image? Very good, Sanghmitra, very good. See, if there is a question which is image based about post-mortem changes, then only there are three entities, and there are four entities, sorry, which you need to remember. One is you can have a image about rigor mortis, or there can be an image which may be showing putrefaction, or it changes like marbling and all, right? Or it can be post-mortem hypostasis, which is known as post-mortem lividity, or it can be mummification. Clear? I haven't seen any question about saponification in the image-based format so far, so I am skipping that, right? So there are these four conditions which everyone has to study properly, and most of the time, in one or other way, you will have a question from this area. It has been observed since long, right? Now, as far as this particular thing is concerned, especially for those students who are new to this session, what you can see here, you can see some greenish discoloration. What you can see here is greenish discoloration, okay? And the moment you find greenish discoloration, you have to answer only one thing, that is putrefaction. So greenish discoloration actually help us, and this again, sometimes it has been asked like from where it starts or where it is early noticed. So it's better I write it early noticed in. If we look the body from outside, that is externally, then it is of course right iliac fossa, okay, which is the area overlying the cecum, which contains large number of bacteria. And if we open the abdomen, it is seen on under surface of liver. Clear? Yes, Shanavas, right iliac fossa. Sanghmitra, absolutely right. So this is in short about putrefaction, and sometimes you can see marbling, which will be something like this, okay? So you can see marbling, and that marbling is because of the hemoglobin which is which is released from RBCs, and that lines the blood vessels, okay? So that is marbling. So you can remember that. So again, it's just like maybe seen around 24 to 48 hours, and that is just one of the process related to putrefaction, okay? So this is putrefaction which is being shown in the image, and in simpler words we call it decomposition. And as far as rigor mortis is concerned, that is post-mortem stiffening, post-mortem hypostasis, there is pooling of blood over the dependent parts, and mummification, there is drying or desiccation of the body with preservation of the body features, okay? So this is putrefaction. Now, okay, next question is about rigor mortis also, okay? So in rigor mortis, sometimes we have question about like what muscles are affected first. So again, you have to specifically check the question statement whether they are asking about all muscles or they are specifically asking you about voluntary muscles. So this is very important, because if they are asking about all muscles like voluntary, involuntary, then it is myocardium. Clear? Myocardium means heart muscles. And if they are specifically asking about voluntary muscles, means which we actually move, so that relates to the eyelid. So it is the upper the eyelids, right? So this is in short which you need to remember. And then there is one important fact, that the rigor mortis, it will come in a sequence and it will go in the same sequence. So that is very important and very unique feature of rigor mortis. So the order of appearance of rigor mortis in muscles is the same order for disappearance of rigor mortis from the muscles, right? So rigor mortis disappears in same order of appearance. So if I say rigor mortis disappears from which muscle, then answer would be myocardium. If I say rigor mortis disappears first from which voluntary muscles, then again the answer would be eyelids, right? So appearance, disappearance, the sequence remains the same. Sangmitra, yes, you are absolutely right. If there is no specified there is no specification about muscles, then answer has to be myocardium. Okay, so just remember like that. Now there was one question about gastric lavage is contraindicated in all of the following except, right? So it means this contraindicated and this except will nullify each other, and now you have to tell me in which condition we can do gastric lavage. Now gastric is stomach and lavage, you can say wash. So we just want to wash the stomach so that all the poison which is present within the stomach cavity is taken out, and because if it will stay in the stomach, then definitely it is going to absorb. So it's better we just take it out as much as possible and as quick as possible. Stomach washing, yes, right. Now in which of the options you would like to do gastric lavage? Very good, very good. The answer is phenol or carbolic acid, right? Just remember one word, that gastric lavage is never done in corrosive acid poisonings, except, and there is only one exception, and that is carbolic acid, right? For rest all, we should not do gastric lavage, as there are chances of perforation. So don't do gastric lavage in HCl, H2SO4 or HNO3 poisoning, right? So the answer is phenol or carbolic acid. So this is the assembly of gastric lavage. We just try to remove the poison as early as possible. Now the next question is, I think most of you must be knowing, which of the following will not be the same even in identical twins? Now we know that the identical twins, they have the same genetic makeup, and most of the time they look so they look almost identical, but the fact is that fingerprints are so unique that even the two identical twins, they don't have the same fingerprint. So this is known as Quetelet's rule, right? So this is known as Quetelet's rule. Mohammad Shahnawaz, Sangmitra, absolutely right. So this is the fingerprints, they are not same even in the identical twins which have the same genetic makeup. So that is so much uniqueness of the fingerprints. Chalo. Next question was about preservative for storing viscera in toxicology for chemical analysis. So which one is not used out of the four? because whenever there is a case of poisoning and we have to preserve viscera, we use certain chemicals. And out of these four options, which one is of no use for us in viscera preservation in toxicology? Any idea what can be the answer here? I think the answer is not that tough. Very good, Shahnawaz bhai. The answer is glycine. So it has no role whatsoever. And I think formalin, you must have heard that whenever we have to do any histopathological examination. Sangmitra, absolutely right. So formalin is quite clear that whenever we have to do any, histopathological examination, we preserve the sample in formalin. So formalin is quite obvious. Now apart from this, we also use rectified spirit and we also use saturated salt solution, right? So these two are also used. So the answer is glycine. And the saturated salt solution and then the rectified spirit, right? So rectified spirit is usually for acid poisonings except carbolic acid, and saturated salt solution just except the poisonings except the acids, right? So we can use the saturated salt solution or the rectified spirit. And formalin, I think most of you must be knowing that it is always a valuable tool for doing histopathological examination, right? So just remember these three names as far as the preservative in toxicology is considered. Now this is a very beautiful question, and I would like to actually discuss the concept with all of you, so that in case if such a question comes there, you should be in a position to give it a thought to reach up to the answer. Now here now this is not a patient, actually it's a dead body, right? So there is a dead body and he is having gunshot injury. Okay, now what we can see here, there is burning, blackening, tattooing, and then there is cherry red color around wound. Now what kind of injury is this? Sangmitra, yes, you are right, but there are two options which you need to rule out to reach up to the right answer. So you have to choose from the two to get to the perfect answer. Now here, very good, it's entry. Now for those who are starting the forensic for the first time, I have kept two options here. One is contact shot and another is close shot. Okay, so now what happens? As the name suggests, contact shot, it means if suppose this is the part of the body, the muzzle is in closed contact with the body, right? So this is known as contact shot. Now what will happen whenever there is a contact shot? Now deep to this is say this is skin. Okay, deep to the skin there is bone. Okay, so this is the bone. Now what will happen whenever there is a contact shot? There will be the bullet which will come out, and because of this there will be lot of gases here. And what they will do, they will lift the skin something like this, and that will actually invert the wound margins, evert the wound margins. So that is number one. But more importantly, what they will do, they will create lacerations, and therefore the entry point will appear something like this. So this is known as stellate shaped entry wound, right? So stellate, or in simpler words you can say star shaped. And this is because actually those air or gases which were present within the skull and the skin, they were so, they were having so much of force that they have torn the skin and then they came out. So they will create a stellate wound, right? So that is very classical for contact shot. So now in this particular question, let us apply this concept. Now if you look here, what we can see, we can simply see a somewhat rounded wound, right? So it is not a stellate entry wound, it is a rounded. So it means we can easily cut down these two options. That of yes, it is not going to be a contact wound, right? And especially the entry one, right? Not this one. So this is not a contact entry wound, number one. Number two, what happens whenever the bullet comes out? So suppose if this is the skin, right? So if suppose this is the skin, and this is the point of entry, and this is the skin from the point of exit. So what the bullet will do, the moment it comes out, it is again going to evert the margins of the skin. So eversion of skin margins or wound margins, right? So again in this image we cannot see any sort of eversion. Yes, there can be some possibility of inversion here. Now what does the inversion mean? Inversion means the skin margins would be rolled inward. So that is known as inversion. So skin margins will be rolled inwards. Inwards, so that is inversion, right? So in this image it looks more of inversion rather than eversion. So we can also exclude the exit wound here. And based on the same concept, we can also exclude the concept of exit wound of close shot. Now this is, of course, as Sanghmitra said, this is close shot entry wound. Now what else you can see here? And if you see, you can see this, there is some reddishness here, right? So this is one point which has already been mentioned in the question as well. So there is reddishness, clear? Then you can see some blackening like this. So you can see some blackening here, right? Then even in the surrounding part you can see some staining, that is known as blackening or tattooing, right? So there are few terms which are known as, one is tattooing, okay? Then there is burning, which is actually known as singeing, especially singeing of hairs, right? So these are few terms which are very indicative of close shot entry wound, right? So this is basic concept. Now I just kept few images just to help you out. So this is the first picture is contact entry. Now this is the muzzle end, okay? So this is the muzzle end of the gun which was in contact with the point of shot, and this is the bone here, okay? So this is the bone here, and of course outside the bone is all skin, okay? So this is the skin here, right? So this is the skin. Now this is bone and this is the muzzle or the tip of the gun, whatever you say. Now what happens whenever there is firing from such a close distance, the bullet will go right inside and it will leave so much of gases in this area between the skin and the skull, and that will lift, or you can say that will push the skin outside, and this will also result in the tearing of the skin, right? So there are lacerated wounds over the skin, and that gives a classical stellate shaped entry wound, right? So the moment you see a star shaped entry wound, simply go for contact shot, simply contact shot, right? So there is ballooning of skin, and we have just discussed, because the gases which are present between the skin and the bone, now they can't do anything to the bone. What they will do, they will just simply push the skin outside, so that will cause ballooning, and this will cause stretching of the skin, and finally there is tearing, and this tearing is actually responsible for these stellate shaped shape, right? So this is the contact shot. Now here there is one more important point which is shown here. Now look at the levels of the skull bone. Now suppose if this is the skull bone, right? We are just discussing the skull bone now. So if you see, it is shown something like this, right? The bullet is coming from this direction. Now just a little bit of anatomy about the skull bone. The skull bone has got a outer table and a inner table, right? So like in long bones we have cortex, in a skull we use the word table, right? So we don't say cortex here. So there is a outer table and a inner table, and in between the two we have diploe, right? So this is the diploe. Clear? Now what? Now just look here, the same thing in the lower part also. Now see what is happening here. There is a slope, so you can see a clear cut slope, and this slope is known as beveling, right? So this slope is known as beveling, and therefore just because of this beveling, if you look at the size, it changes. Here the size is this much only, but over the inner aspect of the entry wound, the size is lot bigger, right? So that is very important. Beveling is seen. It means the size is small on one end, the size is bigger on other side, and that is because of beveling, right? So that is the thing which has been shown here. So this is beveling. So this is in short about contact wound, contact entry wound. I am very sure you won't miss it anyway. Now the second is the close shot, right? So the very first thing about the close shot is just look at the shape. So if you look at the shape, you will see that it is circular. So one important help or clue is circular shape of wound, right? Then in this area you will have different regions. The innermost is the abrasion collar, which is also known as the dirt collar or grease collar. So the innermost is the abrasion collar or dirt collar or grease collar, which is surrounded by the area of singeing or blackening, right? So this will be surrounded by, this all area will be surrounded by, so this black portion is actually abrasion collar or grease collar, and this will be surrounded by tattooing, singeing or burning or blackening. So this is, say, this is first, this is second, and then third is all tattooing, right? So you will see 3 zones in close shot entry wound. Okay, so this will help you in getting up to the answer. So there is singeing, blackening, tattooing, everything which is a feature of close shot entry wound. Okay, so if you look in this particular image again, I think you can clearly see that the size is circular, Then we can see the grease collar, right? Then it is surrounded by singeing and finally tattooing. Okay, so this is a classical close shot entry wound. And how does entry wound and exit wound differs with respect to the skin? Now what happens, whenever the bullet enters, it will also take the skin margins inside. So this is known as inversion or inverted margins, right? And when this is entry of, okay, and when it will come out, again it will take the skin margins along with it. But here, since this wound is exit, so this will be known as eversion or everted margins, right? So it's better I write everted. Inversion is actually anatomical term, right? So this is inverted, right? So inverted and everted skin margins. Clear? So this is how the skin margins look like. So I think there are these few basic words, and I hope that by the end of this session you must be very clear about contact and close shot wounds at least. Okay, chalo, good. No, let's move forward. And then there was one question which was about the time period of fusion of base occiput with base sphenoid. Now this is all just memorizing the facts, and there is no concept as such. It is just a numerical or value based question, and you have to simply you should know the time period as such. Now what I'm more interested here in showing what actually base occiput or base sphenoid is. So as the name suggests, we are discussing something related to two bones. So one is the base of occiput and another is the base of sphenoid. Now if you look in the image proper, this is all occiput bone, okay, and this is all sphenoid. So this part is all end of sphenoid, and this is the end of occiput. Okay, so this junction is known as spheno-occiput junction or joint, right? So the question is about this particular Sangmitra. Yes, you are absolutely right. This is between 20 to 22 years. Perfect. So the question was about the time period of fusion of these two bones. Okay, so this was about 20 to 22 years. And again, in this image, I think it will be, because this is just a skull sample. Now here you can see this this area is sphenoid and this is occiput. Okay, so this particular point is the base occiput and base sphenoid junction. And again we are looking at the skull from the base, and this is known as norma basalis. So we are looking at the base. Now the same thing we can see when we remove the vault, and we can see the internal of the cranial cavity. And here also you can see the orange part is all sphenoid and the pink part is all occipital bone, right? So this area is the base sphenoid and base occiput junction. So this is what I just want to demonstrate, that what actually the landmark which we are discussing in this question. And yes, the answer is 20 to 22. So somewhere between 20 to 22 years, right? So it fuses at this time. They are two separate bones, but then they become one single piece of bone. So the answer is between 20 to 23 or 22 years. Okay. Now the next question is earliest skull suture to close. Yes, any idea what is this? What is the answer to this question? Earliest. Yes, anyone? And I think all of you must be knowing what actually sutures are, because skull contains many component bones, and these component bones, they are held by sutures, and these sutures, they ossify with time, right? So see, there is one metopic suture which is present between two frontal bones, right? So these are frontal bones, actually two separate, and there is a metopic suture, something like this, and this fuses very early. So as early as 2 to 4 years, right? So the metopic suture is, and most of the time when we discuss, we always take frontal bone as a single bone, but actually it was in two pieces. So this is frontal, right half, left half, and in between them there is metopic suture. So this was metopic suture, and sometimes also known as frontal suture. So this closes so early, somewhere around 2 to 4 years, and all the remaining sutures, see, the sagittal is taking around 30 to 40 years. Similarly, the coronal is also taking around 40 to 50 years, and lamboid is also taking around 40 to 50 years to close. So all these sutures, they take a lot of time. It is the metopic one which is uniting so early, and then therefore in most of the discussion we never discuss about metopic suture, right? So anyway, just remember, metopic suture fuses early and followed by sagittal and coronal plus lamboid, right? So coronal and lamboid are taking so much of time, and this is like this. You can remember the sequence like this, okay? And these are almost same, right? Now, earliest organ to putrefy. We already discussed what putrefaction is. It is the decomposition of dead body, right? So which very good, Shanwas, very good. Yes, it starts with the respiratory tract, and yes, it can involve brain and other parts also. So the early putrefaction, which is seen in 24 to 48 hours, it starts from larynx, trachea, brain, right, some part of GIT, and then late putrefaction, which is 2 to 3 weeks, it will involve the, the latermost are the prostate, testes, non-gravid uterus, and ovaries. So these are the last, right? So these are the last, and this is the earliest. Clear? So just remember this. Yes, absolutely right, Sangmitra, absolutely right. So larynx, trachea, same thing, no problem. So just remember this. What is earliest, what is last. That's enough. No need to mug up the entire table. Now, what is the order of mummification? And I think it's very easy. Everyone can answer it. This is a process of, drying of dead body, which is preserving of bodily features. So if you have heard about very good, very good. If you have heard about mummies of Egypt, like the bodies, they are almost dry, and you can just look at their face and you can get to know like how they might be looking. And there is no odor. Yes, there is no odor as such. So these are odorless, and this is promoted by dry air conditions. Okay, so windy conditions, dry, there is free airflow circulation around the body. So free airflow or circulation around the body, right? So this will promote mummification. Fine. So there is no odor to that. Shanwas, absolutely right. Sangmitra, absolutely right. Now, what is this McNaughton's rule? Any idea what is McNaughton's rule? This is actually criminal responsibility of the insane. Very good, Shanavas bhai. So it is criminal responsibility of the insane. So very good, Narsimha, very good. So it means if someone is committing a crime and if it is proved that he was not of a sound mind and he was not knowing actually what he is doing and what is going to be the implication of that act, then in such cases, yes, Sangmitra, they cannot be held guilty of that crime, or they cannot be held responsible because they were not in that state of mind to assess that what is going to be the outcome of this particular act. So that is what is addressed in the McNaughton's rule, which relates to the criminal responsibility of the insane, and it says if a person is not of sound mind, so we use this word sound mind, while committing the crime, right, so as to ascertain what is the nature of that crime, he cannot be held guilty, right? So this is in short I have written. So if a person is not of sound mind, he cannot be held guilty for the act he has done. So if just an image I have kept, like I wasn't in a sound state of mind when I shot him, so this all will go in defense of the accused. So that is McNaughton's rule. Now, turquoise bluish discoloration of stomach mucosa. This is a post-mortem finding for which poisoning? Turquoise bluish discoloration. Any idea? Turquoise blue discoloration of stomach mucosa. Because these kind of questions usually come like discoloration of stomach mucosa, or very good Sangmitra, very good sodium amytal capsules, or sometimes they can ask you about like color of post-mortem lividity, or even like specific odors, like as we just discussed, garlic odor for arsenic poisoning, right? So they can use those words in framing questions, so you should have a fair knowledge about that as well. So this is about sodium amytal capsules actually. Clear? So this is turquoise blue discoloration. Very good, Shanavas bhai. Initial words are right. I think you must be knowing the full answer as well. Now, next question was about the poisons. So, proximal tubular damage of kidney is done by all of the following except, it means out of these four options, which poison does not affect or which does not cause injury to kidney. Out of these four options, which does not damage kidney? Anyone? Proximal renal tubular damage. This is actually phosphorus, right? So phosphorus is usually hepatotoxic. Okay, so just remember this much, especially yellow phosphorus, that is hepatotoxic. Okay, so it has no effects on renal PCT. So that is chalo. Now what is this Locard's principle? What is Locard's principle? And if you know the complete term, and that is actually known as Locard's principle of, very good, yes, Narsimha, Sangmitra, both of you are right. So this is actually Locard's principle of exchange, right? And it says that whenever, Shanavas bhai, absolutely right, this is fingerprints. Narsimha, absolutely right, yes, exchange. So it says that whenever two things come in contact, there is always exchange of things, right? And this is actually in terms of crime. So whenever there is a criminal who is doing something, so he might leave some clues and he might take something from there, Yes, very good, Narsima. So there will be, you know, there might be some, you know, some body hairs might remain at the crime site, or if there is carpet, he might have some carpet threads in his shoes, like that. So there is always some sort of exchange of things whenever two things come in contact. So that is what, in terms of forensic, that is what is defined by the Lockhart's principle of exchange. And of course, yes, if someone is, you know, doing crime, there might be fingerprints on the, any gun, or you know, some objects or whatever. So there might be fingerprints of the accused. So this is what Lockhart's principle of exchange actually defines, right? Then what is this posthumous child? Any idea? Posthumous child. Any idea what is this posthumous? Very good, very good. So this is actually, post means after, right? Post means after. So after baby is born, after death of biological father, right? So the original father. Clear? And this is usually seen in yes, Mohan, Shanwaz, Sangmitra, Narsimha, everyone is right. And this is even like, we know there is one relative of us, like, whose father was in army, and he was just 2 months intrauterine when his father was killed in conflict. So that is posthumous child, right? So especially seen in, you know, military or other defense setups. So this is the wife was already, you know, pregnant, and later on the father, he was killed or died, whatever. So this is posthumous child. Okay. And there are few more terms. One is atavism. Now what is this atavism? Any idea? Atavism, I think we have discussed a little bit. So the newborn baby, very good, Sangmitra, very good. So he resembles grandparents, not parents, right? So this is atavism. He is resembling grandparents and not parents. Then there is another word, superfetation. So these are few definitions which you should know, and many times you have seen the questions are coming from these straightforward definitions. Now what is this superfetation? Now here, if you see, there is word fetus, word is here. So it means there is already one fetus which is in the uterus, okay, and there is, on the top of that, there is another fetus which is now developing. So this is known as, very good. So yes, so this is known as superfetation. So suppose this is cycle 1, and here the ova was released, which was fertilized by sperm, and there is first fetus. After some time, there is second cycle, second ova was released, which was fertilized by another sperm. So this is act 1, this is act 2, and this has also resulted in second pregnancy, that is second fetus. So pregnancy is two different, yes. So this is superfetation. And there is one more term which you need to differentiate, and that is superfecundation. Now what is this superfecundation? Here cycle is 1, then there are 2 ovas, right? So 1 ova and second ova, right? And these are then fertilized by sperms, right? So they're also resulting in pregnancy, right? So the main difference is in terms of the cycles. Okay, so this is superfetation and superfecundation. Clear? So just make sure that you don't mix up in these valuable definitions. Okay, very commonly asked. So in superfecundation, the cycle is same, but ova are released at different times, and in superfetations there are two different cycles and two different ovas are fertilized. Clear? So I think this is enough for this session. I am extremely thankful to all of you for sparing your valuable time for me, and very shortly I'll come up with another subject. So see you all. Good night. God bless.